welcome back. Good evening, my friends. So today we are having a very interesting, important, and exciting topic in the sense often seen, very often missed, and unless our mind knows, our eye also cannot see and define. So today we have got a primary immunodeficiency disease and the whole spectrum. And the lead discussant is no other than Professor Surjit Singh, the man who has pioneered this concept, and he is the chief, as you all know, is the chief of pediatric immunology and the advanced center and the pride of the nation, IPGMER Chandigarh. Along with him, Professor Amit Rawat is there. He's also a faculty there with the Dr. Vignesh is an assistant professor. And I think all of us need to know all these things, and it's that Professor Singh will deal with all his teammates on this topic, and I can assure you, everybody will feel so comfortable to deal with the disease, and we are planning to have some exposure in his center, hands-on, later on, after some time, after this pandemic is over, as we are discussing. So let's start the topic today, Professor Surjit Singh. Now you can initiate the program. Thank you very much.
Good evening, Dr. Alkendu, and thank you very much for inviting us for this meeting. So I shall be talking about a clinical approach to primary immune deficiencies and shall try to show that, number one, these disorders are not uncommon. They are definitely not. It is possible to make a syndromic diagnosis of these conditions without much difficulty. The molecular diagnosis will take time. The genetic diagnosis is sometimes difficult, but one can be reasonably sure that what you are dealing with, number one, is a primary immune deficiency, and that it fits into one of the PID syndromes. There are more than 400 or more than maybe 450 such disorders now, but if you approach them systematically, you can come to a reasonable diagnosis in a large number of patients. There are patients who fox you and in whom the diagnosis can take sometimes weeks, months, but in majority of the cases, you are at least sure that you are either dealing with or not dealing with a primary children great torments. And Dr. Levinsky had the credit of starting the PID unit, the first PID unit in the UK. And he was always very fond of saying that we should simplify immunology. And he tried to bridge the gap between the laboratory and the bedside to the best extent that he could. He always used to say diagnosis of PIDs is not difficult. Not many people agreed with him at that time, but I think over the years, this is something which all of us now have come to realize. And it is possible to make a syndromic diagnosis of PIDs at the bedside. With some experience, it's not difficult to make these diagnoses. So from the clinical point of view, we identify the PIDs based on age of presentation, the type of organism, and family history. These are three important clues how one can identify the PIDs. And based on these three things, in majority of the cases, you can come to a reasonable diagnosis. How does age of presentation come into the picture? Well, most of the serious cellular immune defects would appear between birth and the first 6 months of life. And the dreaded immune defect in this age group is severe combined immunodeficiency, which, if not picked up, is almost always fatal. Humoral immune defects, on the other hand, do not appear in the first 6 months of life. The reason is that the maternally derived IgG protects the baby for the first few months of life. IgG, we know, has a half-life of around 3 weeks. So till 4 times the half-life, it has some protective effect on the baby. So humoral immune defects appear after the first 6 months of life, while most of these serious cellular immune defects would appear soon after birth. So that is one important way how we get a lot of information from the age of presentation. For instance, if a child has survived, say, 2 years or 3 years, we can be reasonably sure that he would not be having most of the common types of severe combined immunodeficiency. So the first few weeks or months, disorders that present are severe combined immunodeficiency, severe congenital neutropenia, DGOT syndrome, and leukocyte adhesion defect. Disorders that present between 6 months to 5 years, the most important is X-linked A-gamma globulinemia, previously known as Bruton's disease, Wiskott-Aldrich syndrome, and phagocytic defects like chronic granulomatous disease. Disorders that appear after 5 years in adolescence or sometimes even in adulthood, the most important is common variable immune deficiency, a disorder that is often missed, completely missed. Specific antibody deficiencies, complement disorders, ataxia telangiectasia, they also may appear later. But since most amongst the audience would be adult rheumatologists, we must remember that common variable immune deficiency is being missed in our country to a very large extent. The type of organism again gives very important information to the clinician. So in cellular immune defects, the infections are by a large repertoire of microorganisms. These disorders are very serious. They appear in the first few weeks or first few months of life, and the repertoire can extend from organisms like pneumocystis, mycobacterial organisms, fungal, cytomegalovirus, bacterial. These children typically fail to thrive. They have a rash, they have oral thrush, pneumonia, diarrhea, hepatosplenomegaly. This clinical picture is sometimes so typical that if you have seen a few patients of severe combined immunodeficiency, you can virtually make a bedside diagnosis that this baby is likely to have a severe combined immunodeficiency. Humoral immune defects, on the other hand, the typical example being XLA, as I said, they appear after first 6 months of life. The repertoire of organisms, infections is much more restricted. Here, infections are by encapsulated bacteria, usually pneumococcal infections, uh, Haemophilus influenzae infections. You may have problems with Giardia, sometimes enteroviruses. The typical clinical presentation will be recurrent sinopulmonary infections. So the moment we have a baby or a child who has had 2 episodes of pneumonia, he is otherwise not too unwell, we would think of a humoral immune defect. Sometimes recurrent gastrointestinal infections can also occur in these patients. In phagocytic disorders, these children can present in infancy or early childhood. The type of infection, again, the repertoire of organisms is very restricted. You will have infections with Staph aureus, Aspergillus, Candida. It is so typical that the moment you have Aspergillus or Candida infection in a young baby, you would immediately think of chronic granulomatous disease. So these are what are known as signature organisms for chronic granulomatous disease. If you have Serratia infection in a baby, it's almost always chronic granulomatous disease. So this repertoire of organisms is very different from XLA, is very different from what is seen in severe combined immunodeficiency. So based on which infection you are having, you can get a fair idea of what you are dealing with. Children with CGD not only have a very restricted and very typical set of organisms, the clinical picture is also like pneumonia. And this pneumonia, unlike that seen in X-linked A-gamma globulinemia, will usually be a smoldering chronic kind of pneumonia. As a result, many of these children are often misdiagnosed as tuberculosis. They have lymphadenopathy, they can have hepatosplenomegaly and liver abscesses. Complement disorders, they can present at any age. The type of organisms are again very narrow, restricted repertoire, either Neisseria infections or encapsulated bacteria, pneumococcus or H. flu. These children, the clinical presentation is like that of X-linked agammaglobulinemia, recurrent bacterial infections, but they can also present as lupus syndromes. So whenever you have very early onset lupus, we must rule out complement defects. Another typical presentation is hereditary angioedema, and children who have hereditary angioedema, if you have seen a couple of these patients, the diagnosis is so straightforward. It's a clinical diagnosis in majority of these patients. The family history again is very important when we are dealing with primary immune deficiency. There are several disorders which have X-linked recessive inheritance, the chief amongst these being severe combined immunodeficiency, X-linked agammaglobulinemia. Several types of chronic granulomatous disease can be there, but X-linked is rather common. Hyper IgM syndrome also has X-linked recessive inheritance. Autosomal dominant disorders, the most important are hyper IgE syndrome and hereditary angioedema. So based on these three clinical findings, age at presentation, type of organism, and family history, we can come to a reasonable clinical diagnosis in many patients. So now what I'll do is I'll just go through some typical patients that we have had the occasion to manage over the last few years. These are all real life patients. We may not have been able to come to the final diagnosis in many of them easily, but each of these patients taught us something uh, very useful. This was a 3-year-old boy with recurrent otitis and pneumonia. The fact that he is 3 years old means that we are not dealing with any of the combined immunodeficiencies. He has recurrent otitis and pneumonia. In other words, recurrent sinopulmonary infections. This is book picture X-linked agammaglobulinemia, and you can notice the absent tonsils here. So you can make a diagnosis of XLA at the bedside. There is hardly any condition in childhood in which you don't see tonsils. Absent tonsils with recurrent sinopulmonary infections, there is no differential diagnosis. Once you suspect X-linked agammaglobulinemia, we will do the immunoglobulins IgG, A, and M, and you can see here that all three are very, very low. We do the flow cytometry, the CD3 and CD19 markers, and we see that the CD19, which is a B cell marker, is almost absent. The CD3 are present normally. So when you have hypogammaglobulinemia with no B cells, this is X-linked agammaglobulinemia. When you have hypogamma with B cells, then that is common variable immune deficiency. So this diagnosis of XLA in this patient was based on the clinical suspicion and the physical finding of absent tonsils, and confirmation required only an immunoglobulin assay and CD3, CD19 on flow cytometry. When do we suspect XLAs? Male children with recurrent sinopulmonary infections, onset more than 6 months, absent tonsils and lymph nodes, and infections by the encapsulated organisms like pneumococci or Haemophilus influenzae. However, in some patients, the diagnosis may not be as straightforward as in this child. This was an 18 months old, previously healthy boy. He presented with acute febrile illness and right orbital swelling. This is how he presented to our emergency. So this can be easily diagnosed as orbital cellulitis. But the resident on duty, and this diagnosis, I'm very proud to say, was made by our junior resident in the pediatric emergency. He noted that this family had had one maternal uncle dying in early childhood. This history and the fact that he had a very severe orbital cellulitis, he became suspicious and he ordered the immunoglobulins, and this child had absent immunoglobulins, no B cells, So this was again X-linked A-gamma globulinemia, diagnosed at 18 months based on the first infection that this child had. So then we were able to confirm the diagnosis by flow cytometry by the absent BTK protein expression and the mutation thereafter. Another patient, 2-year-old boy with fever, refusal to walk, and stiffness of the lower limb. We had no clue what we were dealing with. Fever, refusal to walk, and stiffness of the lower limb. So he had come with an MRI, and this had shown hyperintensities involving L4, L5, and L5S1 region. And there was involvement of the intervening intervertebral discs. Again, we were unable to come to any diagnosis until we took the family history. So this family again had lost 2 male children, and there was history of 2 maternal uncles dying. So typical X-linked recessive family history. So when we had this history of 2 brothers dying in early infancy, we knew that we were dealing with an X-linked recessive disorder. We examined the child carefully. He had no lymph nodes and no tonsils. Whenever you have a young boy with no lymph nodes in the neck and no tonsils, this is X-linked A-gamma globulinemia. Virtually no differential diagnosis. So we got the immunoglobulins and the flow cytometry, again, absent B cells, profound hypogammaglobulinemia. The diagnosis is straightforward. This presentation was so unusual that we reported this child as a case report. Now, since all of us here have a lot of interest in rheumatology, the question arises, can arthritis be the presentation of X-linked A-gamma globulinemia? This is a real-life patient, 7.5 years old. He came from Assam, and he had had arthritis since 3 years of age. And this is the clinical picture that this child came with. He had been treated as polyarticular JIA, nothing wrong with that, because he fitted into the syndrome of polyarticular JIA. However, what was missed there was the history of recurrent episodes of pneumonia and 2 episodes of ear discharge. So when you have this history, you just cannot ignore it. So arthritis is a well-known presentation of X-linked A-gamma globulinemia. And in this patient, we were able to identify the gene mutation. It was an unusual mutation that he had. And arthritis in XLA is usually caused by mycoplasma, but can result from many other organisms as well. It's usually monoarticular. However, in this patient, the presentation was unusual in that it was polyarticular. But otherwise, whenever you have arthritis in XLA, it is usually monoarticular, typically the knee joint which is involved. It usually occurs in older children. So arthritis in XLA will usually not present below the age of 5. It is usually a manifestation of older children. If you're not careful, you can easily misdiagnose it as juvenile idiopathic arthritis. Every year at PGI, we would see 1 to 2 children with XLA in whom the initial presentation is with arthritis. So this is not unusual at all. XLA is one of the commonest PIDs that we see at PGI, and we have recently collated data from many centers in the country on XLA, the various types of presentation of XLA in the country. And this multi-centric study has just been published in Frontiers in Immunology. This is another baby. He presented with this discharging sinus at the neck. He had an axillary lymphadenopathy. He had a liver abscess, and he had a perianal sinus. Now, even if you don't know what you're dealing with, this presentation has to be that of a primary immune deficiency. When you have so many systems involved, you have pus coming here, you have lymphadenopathy, you have a liver abscess, you have a discharging sinus. This has to be a primary immune deficiency. And one should refer the child to a center where facilities for diagnosis exist. But this presentation in this child was so typical. This is book picture, chronic granulomatous disease. So once you suspect chronic granulomatous disease, you can do the nitroblue tetrazolium dye reduction test. But these days, we also confirm it by the dihydrorhodamine test on flow cytometry. And in patients with CGD, there is no shift of the curve. So clinical presentations of CGD, these children can present with recurrent and persistent lymphadenitis, which is often mistakenly treated for tuberculosis. They can present with persistent pneumonia, which is usually fungal. And unless you do a lung tap, you will not be able to get the diagnosis. Lung and liver abscess is again a very typical presentation. And sometimes they can present with osteomyelitis of the small bones and vertebra. Again, this is liable to be misdiagnosed as tuberculosis. So CGD again is not that uncommon PID. We get to see a reasonable number of these patients, somewhere between 5 to 10 patients of CGD every year at PGI. A simple condition to diagnose. This was a 3-month-old infant with non-healing ulcers. Grotesque looking ulcers here in the perianal region. Now, again, if you do not know what you're dealing with, you can be reasonably sure this is some PID. The diagnosis came from the simple hemogram. So when you do the hemogram in these patients, in this patient, the total white cell count was 58,000. And majority of these were polymorphs. There was no pus over these lesions. There was no discharge. There was no pus over these lesions. So the only pediatric condition where you have such high counts, polymorphonuclear leukocytosis, there is only one condition, and that is leukocyte adhesion defect. This condition can be diagnosed based on the clinical findings of very unusual looking ulcers and marked polymorphonuclear leukocytosis. The total leukocyte count in these patients will always be in the range of 50,000, 60,000. And there is virtually no differential diagnosis of these patients. Once you suspect this condition, you can diagnose it, confirm it by flow cytometry. This he found thrombocytopenic purpura and sent the child. After thrombocytopenia persisted, in this patient were these lesions of eczema, eczematous lesions, which had been there almost since infancy. And what had also been missed was that not only did this child had thrombocytopenia, but the mean platelet volume was very low. So the only medical condition where you have microthrombocytopenia, that means thrombocytopenia with small sized platelets, is Wiskott-Aldrich syndrome. The diagnosis based on clinical findings, eczema, petechiae, and a simple hemogram. So many of these children with Wiskott-Aldrich syndrome, they are usually misdiagnosed as immune thrombocytopenic purpura and are treated as ITP for months or years together before the diagnosis can be made. This is a 2-month-old boy with persistent pneumonia and hepatosplenomegaly. 2-month-old boy with persistent pneumonia and hepatosplenomegaly. This baby came from Bihar. And this is the family tree of this patient. This baby had typical X-linked recessive presentation, X-linked recessive disorder. And uh, the, the, the mother of this child had already lost 3 boys. The mother had several sisters, and almost all the sisters had lost boys. So we were dealing with a typical X-linked recessive disorder. And based on the clinical findings of this patient, this was diagnosed as um, uh, chronic granulomatous disease. Very easy diagnosis to make based on the clinical findings that we had, based on the family history that was there. And this was unusual that there were 4 sisters and all of them had had babies with chronic granulomatous disease. And these babies had died in early infancy, but it required so many deaths in the family before before this disease could be diagnosed. So this family reflects the level of ignorance about PIDs that we have in our country. This was a 5-month-old girl born to a 3rd-degree consanguineous marriage. The moment we have consanguinity, we think of autosomal recessive disorders. She presented with fever, cough, rapid breathing. She had thrush. So whenever we have thrush in a small baby, we think of HIV infection. HIV, however, was negative. When we got the hemogram done, this baby had profound lymphocytopenia. The absolute lymphocyte count was very, very low. X-ray chest showed an absent thymic shadow. So oral thrush in a small baby with absent lymphocytes, no thymic shadow. So this is typical severe combined immunodeficiency. The diagnosis can be so straightforward. So whenever you have a very low lymphocyte count in an infant, the absolute lymphocyte count being less than 3,000, there is virtually no differential diagnosis. This is severe combined immunodeficiency. This is the most serious type of combined immunodeficiency. And these patients, unless you diagnose them early, unless you treat them, they will not survive infancy. So it's a medical emergency. Severe combined immunodeficiency becomes a medical emergency. The good thing is that there are several centers in our country now who are diagnosing these patients, and in some centers, there is now reasonable experience with transplantation as well for severe combined immunodeficiency. Again, we have recently collated pan-India data, multicentric data on the various types of severe combined immunodeficiency from all over our country. And this manuscript has been published in Frontiers in Immunology. Now we come to adult presentations. This was a 21-year-old male, HIV negative. He had had chronic fever and cough for 6 months, for which, as often happens, he had been treated for tuberculosis. He had right ankle arthritis. That is peculiar. Tuberculosis with right ankle arthritis. In the history, he had had celiac disease 2 years back, and he had been on gluten-free diet. He had a mediastinal node FNAC, which showed non-caseating granuloma with CD4 plus T cell predominance. So ankle arthritis, non-caseating granuloma, you add 2 and 2 together, this becomes sarcoidosis. But why should this patient also have celiac disease? Why should a patient of sarcoidosis also have celiac disease? So workup was done, and this patient had profound hypogammaglobulinemia. All the 3 immunoglobulins were virtually undetectable. And unlike X-linked agammaglobulinemia, the B cell count was normal. So he had normal B cells, profound hypogammaglobulinemia, and a sarcoid-like presentation. So this is the presentation of common variable immune deficiency. And in common variable immunodeficiency, you can sometimes get granulomata which mimic that of sarcoidosis. Before you confirm a diagnosis of sarcoidosis, it is virtually mandatory to rule out common variable immune deficiency. Otherwise, these patients will keep on moving from one OPD to another. So sarcoid-like granulomas can occur in many organs in these patients with CVID, and misdiagnosis of sarcoidosis in a patient with CVID can lead to inappropriate treatment and can increase the morbidity and mortality. And sarcoidosis and CVID can mimic each other rather closely. This was a 10-year-old boy who presented with pneumonia and recurrent skin abscesses, but the peculiarity about these abscesses were that they were cold abscesses. He had abscesses in the gluteal region, abscesses at the back, and since they were cold abscesses, they had been treated for, they had been diagnosed to be because of tuberculosis. He had received more than one course of anti-tubercular therapy. But then why should he have pneumonia? So workup was done. He turned out to be HIV negative. IgG, A and M were normal, but IgE was sky high, very, very high. A close look at the child showed that he had coarsening of the facies. When we suspected hyper IgE, we also got an orthopantogram done, and this X-ray shows that some of the teeth had not even erupted at the age of 10 because the primary dentition had not still fallen off, which is typical of hyper IgE. So this is one condition where you get recurrent pneumonia with recurrent cold abscesses, coarsening of the facies, several skeletal defects. One amongst these skeletal defects is that the primary dentition does not fall off at its usual time, and these children can have two sets of teeth at the same time. And this is typical of the autosomal dominant hyper IgE syndrome. If you have seen a couple of these patients, diagnosis is not difficult at all. So in these patients with hyper IgE syndrome, you have recurrent staph abscesses, but these are cold abscesses. That means without the inflammation associated with staphylococcal infections. You have pneumonia with pneumatocele formation, autosomal dominant inheritance. They can have eczematous dermatitis. They can have eosinophilia and coarse facial features, which are very, very typical, and delayed primary teeth shedding. This was a patient who came from Nagpur, 9-year-old boy. He had had many, many admissions, HIV negative. He presented with extensive molluscum contagiosum. Now, if you know the diagnosis in these patients, this is a spotter. Extensive molluscum contagiosum, recurrent episodes of diarrhea, poor weight gain since infancy. There can be no diagnosis other than a primary immune deficiency based on these clinical findings. Failure to thrive, recurrent diarrhea, and the only one of the very few primary immune deficiencies in which you can get recurrent molluscum contagiosum is the autosomal recessive type of hyper IgE syndrome. Here again, the IgE will be elevated, and this is because of the DOCK8 mutation. This is another type of hyper IgE syndrome. You get lymphopenia in these patients, and this very typical presentation of recurrent molluscum contagiosum. This again is a bedside diagnosis. So this patient had a homozygous mutation of DOCK8. These children have severe cutaneous viral infections, molluscum, warts, and herpes. Unlike autosomal dominant hyper IgE, these patients lack the coarse facial features and the other skeletal findings. And this is a very serious type of immune deficiency. It's a cellular immune defect and may be fatal if not transplanted. This was a 6-year-old girl who had been symptomatic since 2 years. She had had recurrent abdominal pain, severe abdominal pain. Repeated ultrasound and x-rays of the abdomen had been done. These were told to be normal. And 2 episodes of these pain abdomen were associated with facial swelling, like in this instance. So if you know this condition, this is a spot diagnosis. And the family tree shows that this child had an autosomal dominant disease. The grandparent, the mother also had the same disease, mother's brother also had the same disease. So autosomal dominant conditions are very few, and the one which can present like this is C1 esterase deficiency or hereditary angioedema. The only investigation that you require to confirm this diagnosis is a C4 assay. C4 is virtually absent in this patient. Again, this patient required several years of this clinical features before she could be diagnosed, and the parents and the grandparents had still not been diagnosed. It was only after this child's diagnosis was made that the diagnosis was confirmed in the other family members. How do you suspect it? You get sudden onset of recurrent facial swelling with no itching. This is the typical clinical finding. Unlike allergic angioedema, these patients will develop these swellings without any itching. So it's again virtually a bedside diagnosis. You have recurrent abdominal pain and you have family history. This again was a patient in the early 90s, one of our first few patients of hereditary angioedema. She used to get these episodes of edema around the eyes, and her mother again had these episodes of edema, much less severe than in the child, but she used to have swelling over the hand, sometimes associated with pain abdomen and swelling over the eyes. So again, suggesting an autosomal dominant inheritance. And this is the same child, 3 years of age, at 11 years of age, and now at 20 years of age. This child was treated with stanozolol and is now much better. Another family with hereditary angioedema. So once you are familiar with this clinical presentation, the autosomal dominant inheritance, it's virtually an outpatient diagnosis. You just get the C4 levels done, and C4 is low in these patients, and then you get the C1 esterase deficiency, and if you have facilities, you can do the mutation. So this is again one of our patients in whom the C4 was undetectable in both mother and child, and this is the SERPING1 gene mutation. Dr. Ankur in our department, he has been working on these patients, and he has recently published a small series from our own center of hereditary angioedema. This was a 6-year-old girl with multiple lytic lesions here. This child had been referred from Cochin, and the referring pediatrician was quite sure that she was dealing with a primary immune deficiency. At first glance, this can easily be misdiagnosed as tuberculosis because many lytic lesions can occur in tuberculosis, and or histiocytosis, but this was neither of the two. This child had multiple lytic lesions all over her body, and one of these lesions was biopsied, and on biopsy it showed mycobacterium infection on culture, but this was not mycobacterium tuberculosis. This was because of the bovine strain, because of the BCG. The BCG had got disseminated and it had resulted in these lesions. So this was because of M. bovis infection, osteomyelitis. And we initially thought that we were dealing with chronic granulomatous disease, but the NBT and DHR was normal in this patient. And this was our first exposure to this entity called as Mendelian susceptibility to mycobacterial disease, MSMD. At that time, we were not very familiar with this patient, and the molecular diagnosis in this patient had to be confirmed by sending the sample to a lab in Paris. So these are the tests which we can now do in our laboratory for confirmation of MSMD diagnosis. This is yet another patient. This was an adult patient who had had recurrent lytic lesions on him, and these were associated with Salmonella infection. So patients with MSMD can get microbacterial infections and can sometimes also get Salmonella infections. This patient was in the Air Force, and his diagnosis was made when he was around 33 years old. So recurrent Salmonella osteomyelitis is again a presentation of MSMD. This was a 4-year-old girl who had presented with these lesions on the nails, on the scalp, and fungal culture grew candida. So this is chronic mucocutaneous candidiasis. Again, a type of PID, very distressing kind of PID in which you get candida infections at several sites. This was a 22-month-old girl who presented with recurrent episodes of fungal infection. Again, these were because of candida, nails over the oral mucosa in the genital area. And this again is chronic mucocutaneous candidiasis. But in this patient, this was because of a gain of function mutation in STAT1. Many patients with primary immune deficiencies can present with skin lesions. This was a 16-year-old boy who had been symptomatic since 2 months of life. Imagine, 16 years old, symptomatic since 2 months of life. He had presented with recurrent respiratory infections and skin ulcers since 4 years of age. This is how he presented. Scary looking skin lesions. But again, what you notice is that there is absence of any pus. There is no pus here. So these lesions, the morphological diagnosis is pyoderma gangrenosum. But when you do the hemogram in this patient, what we realized again was polymorphonuclear leukocytosis. 92% polymorphs, and the white cell count is very, very high. So this again is leukocyte adhesion deficiency going on throughout childhood, and the diagnosis being made as late as 16 years of life. This was a 3-year-old girl, symptomatic since 2.5 months of age. Recurrent bilateral ear discharge. 2 episodes of pneumonia. So sinopulmonary infections, but a girl child. So this is not X-linked agammaglobulinemia. She had had developmental delay and recurrent falls. When we examined the patient, the diagnosis is made on physical examination. So what you see are these telangiectatic lesions in the eye. You have decreased IgA and cerebellar atrophy. So this is ataxia telangiectasia. So ataxia telangiectasia can have a neurological presentation and can also have an immunological presentation. A 7 weeks boy, cough, loose stools, respiratory distress. So whenever you have several systems involved, the pulmonary system involved, GI system involved, in a very young baby, we'll be very, very worried. We are dealing with something unusual. You do the white cell count, and what do you see? That there are virtually no lymphocytes. So lymphocytopenia in infancy is almost synonymous with severe combined immunodeficiency. Again, there was no thymus here. And another thing was that the scapula, there was squaring of the lower end of the scapula. So this is a type of severe combined immunodeficiency because of adenosine deaminase defect. And this again, along with the squaring of the scapula, this patient also had cupping at the ends of the ribs. And this is a presentation of ADA deficiency SCID, but the initial suspicion is from the absent lymphocytes that were seen in this patient. This was an 8-month-old boy who was admitted with severe pneumonia, not responding to IV antimicrobials. So whenever you have a baby or a child with severe pneumonia who continues to deteriorate in spite of antibiotics, you must suspect an underlying immune deficiency. So this child was admitted in our department, had very scary looking pneumonia. When the workup was done, what do you see here? That the polymorphs are very low, only 10% polymorphs. When a child has a bacterial pneumonia, you would expect the polymorph count to be very high. However, in this case, there was the absolute neutrophil count was very low. So you become suspicious. What are you dealing with? We got the immunoglobulins done. The IgG was very low. IgA is low, but look at the IgM. This was elevated. The upper limit is 1.6, and what you had here was 2.8. So neutropenia with raised IgM. So this is hyper IgM syndrome, and patients with hyper IgM syndrome can have life-threatening pneumonia. But the diagnosis is again straightforward. If you know that, if you can pick up the neutrophil counts, the low neutrophil counts, and you notice the raised IgM in presence of hypogammaglobulinemia. So this is hyper IgM syndrome, and not very difficult to diagnose, provided you keep your eyes and ears open. This was a 5-year-old boy who presented with discoid lupus-like lesions. He had had seizures at, and along with that, he had had cortical vein thrombosis. He had had 2 episodes of pneumonia. Elder sister had died of lupus at 7 years. In this baby, the C3, C4 were normal, ANA was 4+ speckled, and anti-dsDNA was negative. Positive ANA, negative anti-dsDNA, and the antiphospholipid antibodies, lupus anticoagulant, was positive. This was the family history. There was some consanguinity here, and this was the index patient, and he had lost his elder sister. And when we got the C1q levels done, these were very low in the patient, and in the brother also, these were very low. So this is early complement deficiency presenting as childhood lupus, and this is because of mutations in the C1q domain. And Dr. Amit collated some of these patients and published them some time back. And children who have very early onset lupus, we would always work them up for complement deficiency. So these were the defects which were seen in this series of patients. And the C1q gene analysis, we got it done from Dr. Teco Kupers in Holland. So when do you suspect early complement deficiency in a child with SLE? Whenever you have lupus below the age of 5 years, there is family history of early onset lupus. These children are also have associated infections, and often they have positive ANA and negative anti-dsDNA. Children with early onset lupus due to C1q deficiency have predominant skin and neurological manifestations and less of renal manifestations, unlike the other types of pediatric lupus. So 4-year-old boy with recurrent infections and pancytopenia. So we are dealing with the primary immune deficiency. The diagnosis is made on a simple hemogram and a hair shaft analysis. So this is Shediac-Higashi syndrome. So whenever you are dealing with recurrent infections, have a good look at the hemogram. Ask your hematologist to look at the hemogram carefully, interpret the findings carefully, and once you get more experience, you can pick up these children with very few investigations. A 2.5 months old boy who had hypocalcemic seizures, very difficult to treat hypocalcemic seizures, dysmorphism, note the upturned philtrum here. Hemogram showed lymphocytopenia, and flow cytometry showed decreased CD3 T cells. The child had decreased naive T lymphocytes and naive cytotoxic T lymphocytes. So this is DiGeorge syndrome. The typical features of DiGeorge syndrome, they present with hypocalcemia, dysmorphic phases, and many of them have associated immune defects. So this spectrum of PIDs that I have shown, these are representative of what we get to see at our institute. In many of these patients, the diagnosis was made with some difficulty after a lot of workup, but they all have important lessons for us. And as a group, primary immune deficiencies are not uncommon at all. You start looking for them and you'll be surprised at how common they are. Most of these patients are not being diagnosed neither in the pediatric age group nor in the adult age group. And this is a pity considering that 1 in 2,000, almost 1 in 2,000 population has a primary immune deficiency. Thank you very much.
Thank you, Professor Surjit, for wonderful elucidation of such a difficult topic in such a lucid way. So nice of you, and it's only you can do that one. So I think it will be really helpful for all of us, include juniors and seniors, all of us. So if I think there may be some request some clarification from the trainees, if you have got any issues to discuss with Professor Surjit. There's no question in question answer box.
So just one question came just right now.
Okay, I said tell that one, yeah.
This is from Rudrarpan, I think he's from SGPJ. Is nocardia infection in early life less than 1 month characteristics of any particular PID?
Chronic granulomatous. If you get nocardia, we would work up the patient for chronic granulomatous disease. Nocardia will be very, very unusual. So whenever you get these unusual organisms, we must suspect a PID.
Two more questions.
Actually, two more questions. Okay, great. Yeah, tell that.
In adult patients with hidradenitis suppurativa and recurrent fungal infection of the nail, what could be the diagnosis?
If it is because of candida, one has to prove that this is because of candida. And chronic mucocutaneous candidiasis can be because of several immune deficiencies. It can be because of more than one immune deficiency. One which I showed here was because of a gain of function mutation in STAT1. But there are several other types of immune deficiencies again, which can result in chronic mucocutaneous candidiasis.
And next question, yeah.
How to differentiate lupus due to
lupus below the age of 5 is a very tricky proposition. And lupus below the age of 5 is as much a primary immune deficiency as an autoimmune disorder or a rheumatological disorder. So whenever you have very early onset lupus, we'll be very, very careful with the workup. And we would do a complete complement screen. And even if you diagnose this as C1q deficiency, the response to treatment is at best modest. So these children have a very difficult course. Quite often, you are unable to control the disease. The infections can be very severe in these patients. So this is completely different from lupus in older children. It's lupus below the age of 5 is more like a primary immune deficiency than an autoimmune disorder.
One more question. An adult above 40 years presenting with spontaneous angioedema without any triggering factors, how should the workup be like?
Then it could be, maybe allergic angioedema. We would not generally be worried. And it depends on the history. But if an adult has had angioedema since childhood, what happens is that after the age of around, say, 20 or so, the episodes of angioedema become less severe. The most difficult age group in these patients is from 2 years till around 12 years or so, or 15 years or so. So during school age, these children have very many episodes and very difficult to treat episodes. These episodes become somewhat less severe after the age of 20. And then the disease tends to gradually ebb away and die away. So it is possible that some patients may have delayed onset, but in majority of the patients, the first episodes would have occurred below the age of 2. And they are very sudden. They are very sudden. The angioedema appears virtually over seconds and not associated with itching. So diagnosis is not quite difficult in these patients. Clinical diagnosis is not difficult. We have recently had 2 of our patients delivering children after marriage. In fact, both of these mothers delivered during the lockdown. And during delivery, we had to support them with plasma. So electively, we gave them plasma because the stress of delivery can precipitate an attack of hereditary angioedema. So, and similarly, if some of these patients, they required surgery, again, you would have to support them with perioperative plasma because C1 esterase has so far not been made available in our country. So the imported brand is very, very expensive, virtually unaffordable. So whenever you are dealing with acute episodes, life-threatening episodes, we give them plasma, 10 ml per kg.
Sir, another question from Srijitha. 6-year-old boy with chronic zygomyositis, infection of the left thigh with normal DHR.
This could be anything. So fungal infections, which are not because of chronic granulomatous disease, the differential diagnosis can be very, very broad. Maybe Amit would like to take it up.
I think card 9 could be one of the other possibilities. I mean, card 9 defect. I mean, without any immunological investigations, it's very difficult, but that could be one of the other possibilities. I mean, invasive fungal infections are also seen in card 9 defect.
The thing to remember as internists is that whenever you have an unusual fungal infection, think of PID and refer the child to a center where facilities for workup exist. One should not sit on these patients.
Sir, another question: in a 3 to 4-year-old child with recurrent infections with B cell count less than 1%, but normal immunoglobulin level, what can be suspected?
Globulins are completely normal, then this is not likely to be X-linked A-gamma globulinemia. But again, one has to do the age-appropriate immunoglobulin levels. Because in the first 24 months, you have to interpret according to the nomograms.
Another question, sir, can Mendelian susceptibility to TB can present at the age of 16 years? No past history of TB, and she had extensive TB.
Well, MSMD can be because of several different mutations, and some of the mutations are not as severe as others. And in some of the more benign forms, these children can have late presentations. Definitely, they can have late presentations, and for the first time, they may present as adolescents or adults. Just as there are well-known reports of X-linked agammaglobulinemia presenting for the first time in adolescents or in adults. These are known.
Well, I remember one of the cases where the grandmother, the father, and the child were diagnosed with MSMD together. This was a case from Kerala, where the grandmother, the father, and the child. It was probably a STAT1 mutation of MSMD. So the child was picked up first, and then they found out that even the grandparent was affected with the same disorder. So MSMD can be detected at later ages as well.
CGD can also present sometimes in adulthood for the first time. So it's not that PIDs will always start in children.
Thank you very much, Professor Surjit, for this wonderful talk.
Thank you,
so
sir.
Delighted.
Thank you very much. Thank you very much.
So let's move to our second phase of today's discussion. From Professor Amit Rawat will handle this one. As an advanced lab technique in rheumatology, Professor Amit at this moment is a professor of pediatric allergy and clinical immunology at pediatrics department in Advanced Pediatric Center in IPGMER, Chandigarh. Has got research aptitude and is contributed immensely in scientific literatures, and is the recipient of ICMR award in 2018. And he has primary concern is the primary immune deficiencies. So may I request Professor Amit to take up the issues and initiate the program. Professor Amit, please.
Thank you, Professor Ghosh. I'll start sharing my slides. So the topic I have been assigned for today is advanced laboratory techniques in rheumatology. So I would be discussing briefly each of the different techniques that we used for different laboratory tests in rheumatology. And I have placed immunofluorescence at the heart of the whole thing because I still believe that immunofluorescence is important and will remain important even with the advent of highly sophisticated technologies that are available. The other techniques I will be discussing is flow cytometry, nephelometry, something about next generation sequencing, because we all are now have to get familiar with this technology, and also some Luminex-based assays. So first, briefly about immunofluorescence. So the most important test that we perform by using immunofluorescence is the anti-nuclear antibodies. And I've just highlighted here the timeline of the evolution of anti-nuclear antibodies. So it all started with Hargreaves et al. In 1948, when they described for the first time a phenomenon which is known as LE cell phenomenon or lupus erythematosus cell phenomenon in patients with SLE. However, this test was specific, but it was poorly sensitive. It had got very poor sensitivity, and it was difficult to reproduce and standardize. And Lee et al. In 1951 showed that this LE cell phenomenon was due to an antibody, due to a gamma globulin on leukocytes. The fluorescence started by Kuhns and Kaplan's much cited paper in 1950. In 1957, Holborough et al. They showed the homogeneous nuclear fluorescence by sera from LE cell positive sera. And Beck et al. Started immunofluorescence on tissue sections. This was rodent liver sections. However, the use of cell lines, the human epithelioma cell line, the HEP2 cell line, which are now widely used for doing DNA, it was started by Tan et al. In 1982. So this is a photograph of a LE cell. You can see this is a neutrophil which has engulfed a nuclear material. So this LE cell is a harbinger of the anti-nuclear antibody test that we do. However, this LE cell is very cumbersome to do. You have to count different fields to search for these LE cells. It is poorly sensitive, although specific. So this has now been mostly been abandoned in most of the labs, and most of the labs now do anti-nuclear antibodies. So the screening for anti-nuclear antibodies, it started with as I said, with the LE cells, moving on to the use of animal tissue for doing anti-nuclear antibody by immunofluorescence. And since the 1980s, we've started using cultured cells, which are layered on microscopic slides. So important to here realize is that when you have a test with a limited sensitivity, then the threshold for clinical suspicion, clinical significance, and for analytical detection is is very narrow. So whatever antibody you detect with a test with a limited sensitivity will be a clinically significant. It's more likely to be an antibody which has got some clinical significance, because this antibody will be higher in concentration and it will be an antibody of high affinity or avidity. Whereas if you have antibody detection methods which are highly sensitive, then you will end up having a lot of false positives, because the threshold for analytical detection will be quite low, and the difference between the threshold for analytical detection and clinical significance is quite high. So the problem with these methods with high sensitivity is that they will pick up antibodies which are not of clinical significance. They will pick up antibodies which are of poor affinity or avidity, and also the antibodies which are in low concentration. So this is very important to understand. And this cartoon here shows that the specificity decreases as you move on from the LE cell to animal tissue to HEP2, and correspondingly the sensitivity increases. So the LE cell was very poorly sensitive. The ANA-IF on rodent liver had slightly more increased sensitivity, and HEP2 cells, they're the most sensitive method to detect anti-nuclear antibody. So these again are different methodological platforms to detect antibodies, and they detect. It is important to realize that they detect antibodies of different concentrations and avidity profiles, as I've already highlighted. So your ANA you can detect by immunofluorescence on HEP2. You can detect ANA specificities on a line plot or a dot plot. You can also detect ANA by ELISAs. And now there are methods available which are known as addressable bead assays, addressable laser bead immunoassays based on the Luminex platform. So these are different methodologies, but it is important to realize that they detect antibodies which have different concentrations and also different affinities. So why is ANA-IF still the gold standard for detecting ANA? This is because, as someone has succinctly put it, the ANA-IF on a HEP2 cell line, the human epithelioma cell line, is a natural microarray. All the antigens which are present in the nucleus, they are present in their normal spatial configuration, and so this ANA-IF can detect already described antibodies, but it can also detect antibodies which have not been previously described. And most importantly, these antibodies are their natural location and in their natural spatial configuration. So this ANA on HEP2 cell line is a natural microarray, so to say. So this ANA on HEP2 cell lines, it is from the American type culture CCL23. However, it is considered to originate from human laryngeal carcinoma cell line, but there has been reports of HeLa contamination, as has been found out by DNA fingerprinting and isoenzyme analysis. And widespread commercial production of these HEP2 cell lines started since 1980s. These are grown on microlayers on microscope slides, and recognition of over 30 different nuclear and cytoplasmic patterns have been described. So what are the advantages of this HEP2 cell line cells as a substrate? So the nuclei are clearly visible in monolayers, and there is a greatest sensitivity due to greater antigenic expression. They have high specificity due to human origin. Since there is a cancer cell line, there are high cell division rates, allowing identification of cell cycle-dependent antigens. The nuclei are large, since this is a cancer cell line. So the nuclei are large, making nuclear details clearly discernible. There is uniform antigenic distribution. And in contrast to tissues where ANA was performed, there's no obscuring intercellular matrix, which will result in some interference. And these are widely available as immortalized cell lines. So enzyme immunoassay have also been used for doing ANA-IF. The problem with them is that they use either natural antigens or recombinant antigens as a substrate. Some kits, they add nuclear and nucleolar extracts, mainly from Hep2 cells, to increase the sensitivity. However, the problem with the ANA enzyme immunoassays is that they are liable to have a high rate of false positivity because they detect low affinity and low titer autoantibodies. And some antigens which are against conformational epitopes like dsDNA or SMIT might not be detected by these enzyme immunoassay. Overall, if you compare this with the indirect immunofluorescence, they have a good agreement of 90%, but there is a broad range. I mean, it depends from kit to kit, and the sensitivity also varies from as poor as 70% to as high as 90 to 95%, and the specificity also has got a broad range. So it all depends on which kit you are using, and so ANA-IF remains the gold standard for detecting anti-nuclear antibodies. So I've just highlighted some of the common patterns that we see on ANA-IF. So this picture photomicrograph shows a homogeneous pattern. So what is a homogeneous pattern? A homogeneous pattern is when the nucleus is uniformly stained and the mitosis. So this is the cancer cell line. So you have got cells in mitosis. So this is a metaphase. So this is more brightly staining than the interphase cells. So the cells in mitosis, the mitotic figures, they stain more brightly. So you've got a homogeneous staining of the nucleus with staining of the mitosis. So this is a cell probably in telophase, this is in prophase, these are metaphases. So this is your characteristic homogeneous or diffuse pattern. Then you have got another pattern which is known as a speckled. You have two flavors of this. The coarse speckled and the fine speckled. This appears to be a coarse speckled pattern, although the image is not very clear. So in the coarse and the speckled pattern, the nucleus is stained, but the nucleoli do not take up the stain. So you've got the black spaces represent the nucleoli, and you've got this kind of staining, and the mitosis are not stained here. The third pattern, which is shown in this photomicrograph, is a nucleolar pattern. Here, in contrast to the pattern you just saw, the nucleoli take up the stain, and this has also got different patterns like fibrillar, clumpy, or homogeneous. But more important to realize that this pattern is a nucleolar pattern. Then you've got another pattern which is known as the peripheral or rim pattern. And when this is associated with a homogeneous pattern, homogeneous with a rim enhancement, then it is very specific to be of SLE. However, a rim pattern can also be due to nuclear lamins. Then you've got multiple nuclear dots. These are also classified as few multiple dots and multiple nuclear dots. So here, the nuclei, there are the dots which are stained in the nucleoli. And then you have got a pattern which is known as the centromere pattern. So the centromeres are stained in this nuclear pattern, and this is characteristic of the Crest syndrome. So I've just put up these patterns to show what are the different patterns that you can encounter on an ANA-IF. I have not discussed the cytoplasmic patterns, which can also be seen, and they might also have some specificities. So again, just to summarize, what are the difference between the immunofluorescent ANA and ANA by enzyme immunoassays. The unique features of the ANA by indirect immunofluorescence are impossible to replicate in enzyme immunoassays, or for that matter, the newly available sophisticated multiplex bead assays. Hep2 cell has several hundred defined and others yet to be defined antigens, whereas you are limited by the number of antigens that you can coat on a ELISA plate in an enzyme immunoassay, or the number of analytes you can detect by a bead assay. And so ANA by indirect immunofluorescence is a better screening assay. It identifies more antigens and is still the gold standard. And packaging of antigens in distinct locations, the antigens are in their natural state, in their natural positions and their natural spatial configuration. So what have been available recently is also the computer-assisted detection of ANAF patterns. So you've got artificial intelligence and machine learning, where you've got automated platforms which can read the ANA patterns for you. And this is automated Hep2 reading system by Acolyte system, where you just have to, the fully automated platforms are also available, where the entire staining and the reporting is done by the system. So moving on to another antibody which is detected by immunofluorescence, but can also be detected by ELISA, are anti-neutrophil cytoplasmic antibodies. So they were discovered by serendipity by Davies and colleagues, who were actually looking for ANA in patients with glomerulonephritis and ended up finding anti-nuclear cytoplasmic, neutrophil cytoplasmic antibodies. These antigens, these antibodies have heterogeneous targets, and they are predominantly the IgG isotypes, because most of the IgG types are pathogenic. They are of higher affinity. And the targets of these antibodies are enzymes of the primary granules of neutrophils, lysosomes, and granules of neutrophils and lysosomes of monocytes. So the clinically relevant are the antibodies to proteinase, the antibodies to proteinase 3, which commonly represents C-ANCA, and myeloperoxidase, which for the P-ANCA. And they're strongly associated with small vessel post-immune ANCA-associated vasculitides. So ANCA is actually an artifact of fixation. So what happens in formalin, in ethanol fixation, is that the antibodies to the antibodies to strong cations, they come to lie on the nuclear membrane. So whereas in a formalin fixation, they stay in their natural positions. So this strongly cationic proteins like MPO, upon ethanol fixation, they lie on the nuclear membrane. Whereas the weakly cationic proteins like proteinase 3, they remain in the cytoplasm. So the ANCA, and more specifically the P-ANCA, is a artifact of ethanol fixation. So if you fix your neutrophils in formalin, you won't see this P-ANCA pattern. So it's also important to differentiate between neutrophil-specific antibodies and anti-neutrophil cytoplasmic antibodies. Anti-neutrophil cytoplasmic antibodies are associated with vasculitides, some infections, and drug-induced syndromes, and they have got well-defined antigenic targets which are present in neutrophil granules of neutrophils. Whereas neutrophil-specific antibodies, they are seen in non-vasculitic diseases like your rheumatoid arthritis, ulcerative colitis, sclerosing cholangitis, and they show no clear antigenic specificity. So this ANA, that ANCA, the anti-neutrophil cytoplasmic antibody, should be differentiated from neutrophil-specific antibodies. What are the autoantigens against which these antibodies are produced? As I said already, the important targets which are clinically very important are the myeloperoxidase, the MPO, and the proteinase 3, which are present in the azurophilic granules. The other antibodies are the bactericidal permeability increasing protein, elastase, lysozyme, cathepsin, azirosidin, and then in the specific granules, lactoferrin. So these are some of the important neutrophil autoantigens targeted by these anti-neutrophil cytoplasmic antibodies. So the most important, as I said, are the myeloperoxidase and proteinase 3, and they can be seen in the proteinase 3 most commonly is seen in this old slide, so the notation of vaginous. So most common in vaginous, and then but you can also see them in other disorders like your microscopic cholangitis, Churg-Strauss, and renal limited RPGN. And your myeloperoxidase most commonly seen in microscopic polyangiitis, but it can be seen in other disorders as well. And these positivities will vary in different populations. So this immunofluorescence image here shows the typical C-ANCA pattern. So what is a typical C-ANCA pattern? The cytoplasmic is stained homogeneously, but there is interlobar accentuation. So between the lobes, so these lobes of the lobes of the nuclei of the neutrophil, they are seen as these dark hollows, and the cytoplasm is stained. But what's characteristic of the typical C-ANCA is that there is interlobar accentuation. So there is a brighter fluorescence between the lobes of the neutrophil. So this is known as interlobar accentuation. This is characteristic of your cytoplasmic pattern of anti-neutrophil cytoplasmic antibody. In the P-ANCA, which I have said is an artifact of ethanol fixation, it is against your strongly cationic proteins, anionic proteins. Here, there's a uniform staining along the nuclear membrane. So this is your peripheral or P-ANCA. Now I'll move on to the next technique that we commonly used in rheumatology and immunology. It's flow cytometry. Okay. Sorry about that. So what is the basics of flow cytometry? So basically, you've got three components in flow cytometry. Flow is something which is in motion. Cells, cyto is to cells, and metry from measurement. Flow cytometry is the measurement of cells flowing in a single file in a detection system, typically interrogated by lasers, and then you've got a detection system which detects the light which is scattered when the laser interrogates these cells flowing in a single file. And what is the advantage of flow cytometry is that it is a rapid procedure. It can detect simultaneously detect multiple parameters on a large number of cells. And it can detect surface and intracellular proteins. It can detect DNA, RNA, nucleic acids. What can a flow cytometer measure? Flow cytometer can measure a cell size. It can measure the internal complexity or granularity of a cell. It can measure cell function. For example, phagocytosis can be measured. Oxidative burst, as Sir has highlighted in his previous lecture, can be measured by the dihydrorhodamine assay. Degranulation of NK cells and cytotoxic cells can also be measured. This is important for HLH. Some pH changes can be measured. Intracellular calcium can be measured. This can be measured by using specific dyes. And it can also detect the presence or absence of an exogenous fluorochrome, which is labeled to an antibody. And it also provides a relative fluorescent intensity. So what are the components of a flow cytometer? So it has typically three components: fluidics, optics, and electronics. So this figure here shows the different parts of a flow cytometer. So this is the flow cell here. The cells, they are brought in as cells in a fluid stream. They are aligned in a single file. And then the optics comprises of the laser assembly. There could be one laser or there could be multiple lasers. And then you've got interrogates these singly flowing cells in a cells flowing in a single file. The light is scattered in different directions. So the forward scatter detector detects the size of the cell, and the side scatter is detected by the light which is scattered at 90 degrees. And then you've got different fluorescent detectors for different, which are known as your channels, different channels. So another important thing to remember is that there's something known as hydrodynamic focusing. What is hydrodynamic focusing? So you want that cells should be interrogated by laser individually. You don't want 2 or 3 cells being interrogated at the same time. This will create problems. So you have sample core and you've got a sheath fluid around it, and then because of vacuum, you create a pressure, and then the cells are made to flow in a single file. And sample pressure is always higher than the sheath pressure, so that the cells flow move in a single file. So the light sources, earlier they were your arc lamps, but now most of them are lasers, solid state lasers. Then you've got lens for collecting and focusing. You've got different mirrors for determining the path of light. The mirrors are usually dichroic mirrors. And then you've got filters to collect light. So you've got short pass filters, long pass filters, and bandwidth filters. So this shows the optics in more detail. So you've got different lasers. Then you've got lenses which collect the light. This focus the light on the flowing cells. And then you've got different band pass filters, long pass filters, and your dichroic mirrors. And then you've got photomultiplier tubes amplify the signal. So when the light is scattered in different directions. So when a laser beam hits a cell, the part of the light is scattered in the forward direction, and the rest of the light is scattered all around. But by convention, we detect only the side scatter is at 90 degrees. So this is also known as right angle scatter. The forward scatter determines the size of the cell, and the side scatter determines the granularity and the internal complexity. So what are the different forms of data display? So the most simple is a histogram, which is a common way to depict a single parameter. So here you see there are 2 populations of cells, or beads for that matter, so which have different intensities, fluorescent intensities. So one of them is positive and the other is negative. So here the positive population constitutes 48%. And in this particular figure, the positive is this small peak here denotes the positive population. This is 12%. So there are other forms of two-parameter data display. So the most commonly used are the dot plots. Saraj showed you some of the dot plots in his presentation. So each dot represents a single event. So you've got a dot plot, then you have a color density plot depending upon the different antigenic densities. Then you've got your contour plots and your 3D plots. So these are some of the ways to depict data for 2 parameters. However, now you've got different systems different softwares to detect multi-parametric data. Another thing also to remember is what is relative fluorescent intensity. It should be of in a linear scale or in a logarithmic scale. So when you are looking at a limited dynamic range, for example, the difference between normal cells is only 2-fold or maybe 3-fold, then you have to use a linear scale, like here in the upper figure here. When you're doing, for example, a DNA ploidy analysis, you have to use a linear scale. Whereas when you're doing immunophenotyping, where the dynamic range of expression is between positive and negative cells is 1,000-fold, 10,000 folds, or even more, then you use a logarithmic scale. For example, between CD3 negative and CD4 positive cells, the intensity of expression would be highly different. So in this case, you will use a logarithmic scale. So this figure here shows the different cells in a distribution of different peripheral cells in the blood. So the forward scatter, as I said, denotes the cell size, and the side scatter the granularity. So this, and you can draw artificial gates around these cells. So you've got lymphocytes, which have got small size and small granularity. You've got monocytes, which are slightly larger than the lymphocytes. So they've got a higher forward scatter, then they've got higher side scatter as well. And then the granulocytes, which are the largest. So they have got the highest forward scatter, and they also have a more complex and granular cytoplasm. So these are the different populations in the peripheral blood. So in a multicolor experiment, what you can do here, it is shown for only 2 antibodies labeled to different fluorochromes. But you can use multiple antibodies in a given sample and to look for multiple parameters in the same cell at a given point of time. So by flow cytometry in rheumatology, I think what's most widely used in clinical practice is probably HLA-B27 by flow cytometry. So here you gate, this is a forward scatter, side scatter. So these are the lymphocytes that you have gated. Then you've looked at the CD3 positive cells. So these are the CD3 positive lymphocytes, that is the T cells. And then those T cells, you will look for the HLA-B27. So this red line here shows the median sample, the preset marker. So in this case, the median fluorescent intensity was higher than the preset marker at 150. So this is classified as positive. Again, similarly here, this was shown as the preset marker. It was more than the preset marker and classified as positive. So I'll just move on to some other important developments which have taken place. So C-reactive protein, as you know, has got a the response of C-reactive protein in the SLE is quite muted. I mean, like in active SLE, you have a decreased or normal CRP even in active disease, unless of course you have got infections or you have got polycerositis. So why is this so? So this is because of the most of the cases of SLE have a type 1 interferon response. And what does this type 1 interferon response do? It inhibits the transcription factors which are involved in the production of CRP in the hepatocytes in response to IL-6. So the IL-6 is produced, but there is no production of C-reactive protein because of inhibition by because of this type 1 interferon induction. These factors, they inhibit the mRNA expression of CRP, and therefore the CRP protein is normal or decreased in SLE. So how is this useful? I'll just briefly also describe polymerase chain reaction, because the slides following this are where I'll describe real-time PCR. So what is polymerase chain reaction? The polymerase chain reaction, when you have to amplify exponentially a segment of DNA, maybe an exon of a particular gene. So suppose you have to amplify this gene, you make primers for a pair of primers. So and there are different steps in polymerase chain reactions. So first step is known as denaturation. So you heat the sample so that the 2 strands of the DNA are separated. Then you cool down so that the primers you have designed will bind to the 2 ends on the different strands. And then in this this is known as annealing. And then the third step is the step of DNA synthesis, where you add your DNTPs, you use a thermostable Taq polymerase and different buffers. And then at the first cycle, this is the product you get. And then when this cycle keeps on repeating itself, and for example, at the end of 3 cycles, you see here that it produces 8 double-stranded DNA molecules, but only 8 of them are of the right size. So, as I said, that there is a type 1 interferon signature in SLE and also other rheumatological diseases. So how can we detect this type 1 interferon signature? So there are automated platforms like the one from NanoString available, but these are very expensive. So the simplest way is to look at different ISGs, that is interferon stimulated genes. So in the initial papers described by Yannick Crow's group and then by Dr. Volpe et al., there are 6 genes were described along with 2 housekeeping genes. So we have been collaborating with Dr. Volpe and Ravelli at Gasolini Institute in a DST project. And so as part of this project, we are doing type 1 interferon signature in patients with SLE. So how do we do that? The typical workflow is that first we extract the RNA from blood samples, from the EDT anticoagulated blood samples. But what is important here is to note that RNA is very labile. So this is a problem we're having with transported samples. So either we take the sample in a Paxgene tube, it's got some RNA stabilizing solution, or we take in RNA later. We add RNA later to that solution. We extract the RNA, we quantify it, we treat the DNAs to remove any DNA, convert it into cDNA, and then do the RT-PCR and analysis. So we were also provided a plasmid, which has got this construct. The construct has got these 6 genes along with the 2 housekeeping genes. This construct helps us to normalize the expression of different genes, because if you use a control, it will vary from day to day and from different controls that you use. So to normalize that, this construct was made in a plasmid. So this recombinant vector containing this construct of this 6 ISG genes along with the 2 housekeeping genes was developed. This was developed in Dr. Volpe's lab, and he has graciously provided us the same, and we are doing it with this in our lab now. So the plasmid is diluted serially on this RT-PCR plate, and then you can put patient samples also in that tube, in that plate. And this is the standard curve which we get from the plasmid. And these are the copy number variants. And this is the interferon gene score. This is in some of our patients, the elevated type 1 interferon score, which was seen in some of these patients. So why is this type 1 interferon signature important, especially in the relation to rheumatological diseases? So there is a group of disorders which are known as type 1 interferonopathies, and they have got different mechanisms. So pathogenic mechanism, for example, if there are defects in DNA sensing, RNA sensing, or IFN negative regulation, or complement, or some of the proteasome related disorders, then there is a type 1 interferon signature. That there is an increased production of type 1 interferons, and the interferon stimulated genes, their expression increases. So again, this figure here shows the different type 1 interferonopathies which are associated with the elevated type 1 interferon signature. So I'll move on to some other techniques like Sanger sequencing, which are commonly used. So in the standard Sanger sequencing, you perform a polymerase chain reaction. The first PCR is known as a amplification PCR. So you use a polymers, you use your DNTPs and primers. And then when you have got the amplicon, then you do the second PCR, which is known as the sequencing PCR. Here you use only one strand, and instead of the deoxy nucleotides, you use a mixture of dideoxy and deoxy. So what happens with this use of the dideoxy is wherever this dideoxy nucleotide is incorporated, there is chain termination. So it is also known as and wherever this one of these nucleotides is attached, this the nucleotide which is labeled with which is a dideoxy nucleotide, the reaction stops, and then these fragments, different fragments, they are resolved on a capillary electrophoresis, and what you get a readout is a chromatogram. So this was the standard technique for sequencing till 10-15 years ago. However, in the last decade, you've got different next generation sequencing or massive parallel sequencing platforms which are available, which can sequence multiple genes at a time. They can sequence the whole exome, for that matter, whole genome in a matter of a day, or maybe a couple of days. And this, there are different platforms which are available for this next generation sequencing. The most widely used is the Illumina platform, which uses a technology known as SBS, sequencing by synthesis. This is a patented technology. Then the other commonly used one is the electrochemical sequencing of iron torrent. You've got single molecule sequencing on this ZMW arrays by your PacBio. And then nanopore sequencing has come up with this sequencing through this nanopores. So these are the different sequencing technologies which are available. The most widely used are the Illumina and the iron torrent. So what we have been using in our lab is iron torrent system for doing next generation sequencing. So there are different steps which are involved in the iron torrent sample preparation pipeline. So you've got a library preparation where you've got different primer pairs. Then you add your adapters for barcoding. Then you do a clonal amplification, and then followed by sequencing. So how does a iron torrent system detect how does it do the base calling? So the base calling is based on the change in pH. So whenever a nucleotide is incorporated, the nucleotides are added, and whenever there is a nucleotide is added, there is a change in the pH, and basically each cell is actually a pH detector. So this is the workflow. So you've got DNA extraction and quantification. The DNA extraction and the DNA is extracted. The quantification is done by a qubit. Then you do a library preparation followed by a immersion PCR. Then you do an enrichment, and then you load these chips. So these chips also come in different sizes depending upon your application. And then you do the sequencing on the instrument, and then you do data analysis. So this is how the NGS data looks like. So I'll just show a couple of cases. This is the most recent one. This was a young girl with early onset lupus. This was referred to us from Chennai. And this girl was found to have a mutation in the C1R gene. This is a previously reported variant in an African American. I'm not aware if there are any reports of C1R gene defect from India. Then we had got these two patients from Bangladesh who had this C3 gene defect. We had two patients also from Kashmir who had the mutation in this ACP5 gene. As you can see there, they have got very high type 1 interferon score. Normal score is usually less than 2. And this patient has a high interferon score of 12. And this, these two patients, brother and sister, they had a deletion in the ACP gene, and the parents were carriers. Another patient with a defect in a RNase H2B gene, Here the interferon score was not very high, although it was high, but not as much as in the patient with ACP5. And this patient has a missense mutation, homozygous missense mutation in RNase H2. Another patient with a mutation in TREX1, which is involved in DNA. This gene is involved in gene sensing. This was a deletion insertion mutation. And this is the genetic defects in early onset SLE that we have seen at our center. So we've got patients. So as Sir had described, we had seen a few patients with early complement deficiencies, even QA gene defects. So most of them, 3 of them had this common defect, like the G208 termination, and 2 of them had a splice site mutation. 2 patients with CP, and this 1 patient from a young girl with 7R gene defect, 2 with CP. And then we've got some with the type 1 interferonopathies. So I'll just add a word about this XMAP technology because it's widely used, patented by Luminex. So what is this XMAP technology? It is a laser-based analysis. So, but you only use 2 lasers. So these are beads which are coated with different concentrations of fluorophores, and the red laser, it identifies the bead region. It identifies which bead corresponds to which analyte, and the second laser quantifies the signal from that bead. So with 2 lasers, you can do as much as like maybe like 100 analytes on a single cell in a given sample. So the steps involved in this technology. So you add the analyte, you've got different beads, the Luminex bead with a capture antibody, and then you've got a detection antibody, and then you've got the after adding the detection antibody, you add your streptavidine, which is labeled, and you run the sample on the instrument, and then you get the result. So this is the XMAP technology, a patented technology from Luminex, where you can use this method, where you can use this for detecting, for example, cytokines, autoantibodies. It's even been used to detect your anti-nuclear antibodies, different specificities. We have used one of the kits from FITIS to do this. Thank you. I think I missed nephrometry. Sorry. So I'll just also tell you about something about nephrometry. So for detection of proteins, you can use photo detection methods. So whenever a light passes through any solution, part of the light is transmitted, part of it is absorbed, part is scattered, and part is reflected. So what does the different methods of photo detection methods use different light, detect different lights. For example, in turbidimetry, you detect the transmitted light, whereas in nephrometry and fluorometry, you detect the scattered light. And the intensity of the scattered light is proportional to the intensity of the incident light. It is proportional to the concentration of the particles or the analyte in a given solution, and it is inversely proportional to the wavelength. So this is a line diagram to show different parts of a nephrometer. So you have a light source. So earlier, your neon laser, most commonly now LED-based light sources are used. You have a collector, you've got a filter, then you've got a sample cuvette, and then you've got a detector which detects the scattered light, converts this to signal. So this is the different parts of a nephrometer. So this is a immunoprecipitation curve. It shows that the absorption change is the maximum when there is a zone of equivalence between the antigen and the antibody. It keeps rising as the antigen concentration rises, and when the antigen and antibody zone of equivalence is reached, concentration is equal. That is the absorbance change is the highest there, and then again with the decreasing concentration of antigen, this started to go down, and the peak rate of scatter also increases with increasing antigen concentration, but after a point, it reaches a peak and then plateaus off. So there are two different types of nephrometry, the endpoint nephrometry and your rate nephrometry. So in the endpoint nephrometry, the time to reach the plateau is dependent upon the antigen concentration. So in endpoint nephrometer, you take the sample, you add you add the antisera specific for the analyte you want to detect. You measure a background signal. You incubate the mixture for a fixed time, and you wait till that endpoint, and then you take one reading at the endpoint. And the final signal is the end value, the performance you measure at the endpoint minus the background value. This gives you the final signal. So the other method is a rate nephrometry. It has got a shorter incubation time. You don't have to wait. For example, for certain analytes, you might have to wait for 2 to 3 minutes. Whereas in rate nephrometry, you don't have to wait till that time. There is no problem of background interference, but it is more sensitive to pH change and affinity of antibodies. So what are the sample requirements? So typically you use serum, but you can determine proteins in other body fluids as well. If it is a lipemic serum, it might create interference. So you have to either do an ultracentrifugation or filtration. You typically use dilutions to measure samples, which will vary according to the analyte. However, icteric samples, hemolyzed samples do not have a problem in nephrometer, whereas interference occurs with these kind of samples in turbidimetric assays. So what are the proteins that you commonly estimate by nephrometry? So what we are using it is for estimation of immunoglobulins, G, A, M, also IgG subclasses. For complements, C3, C4, and now with the automated nephrometer, we're also measuring the C1 inhibitor. We in a pediatric hospital, we also measure anti-streptolysin 4, which is important. We measure the rheumatoid factor, usually the IgM isotype. High sensitivity CRP, this is measured by latex enhanced nephrometry. Microalbumin, haptoglobulin, serum associated amyloid, and you can measure others like alpha-1 antitrypsin, beta-2 microglobulin, it's microglobulin, ferritin, and apolipoprotein E1. So what are the advantage of nephrometry? It has got a very high precision. It is sensitive. It is easy to perform. It's a fast reaction time, cost effective, and of course, it can be fully automated with the instruments that are now available. So yeah, thank you.
Thank you, Amit, for elucidating one of the very tough components of clinical immunology. And would you kindly elaborate one or two clinical problems where the unmet needs were fulfilled through this advanced application of rheumatology, so that the young minds can visualize the importance of these laboratory modalities in clinical practice?
So what I can remember is about in rheumatology is about the early complement deficiencies. So it started off as looking at our SLE cohort. So we thought that since it's a pediatric cohort and some of the patients do have an early onset SLE with family history and consanguinity, so we thought that some of them might have some monogenic defects of SLE. And so we started there, and initially you don't have to do very fanciful assays. You can just do a CH50. CH50 is a test to perform the test to look at the classical pathway of the complement. And in early complement deficiency, the CH50 is absent or practically nil. And then you can look at the early complement components like C1q, C2, C3, C4. Actually, I didn't specifically put up cases of PIDs because I thought it is more centered to rheumatology.
Okay. Fine. So I think there is no question in question answer box at this moment.
Was it
Yeah.
too difficult?
So people are thinking it's not for us. We and they. These are for the research scientists to deal with. We'll just refer the patient to them, and they will solve the problem.
But the ANA would be useful for everyone.
Yeah, that's right. Now, for that reason, we plan to discuss this one in this forum so that people can have some insight to visualize what are the things that can easily be done as depicted by Professor Surjit and you. Yes. Yeah, Dr. Vignesh, right. So thank you, Professor Amit Rawat, for giving the wonderful insight for this advanced rheumatology laboratory technique. We can move to our next session, and that's another exciting sessions. And for the young minds, we have Dr. Vignesh, who is an assistant professor at this moment in the Advanced Pediatric and Clinical Immunology Center in PGI Chandigarh. By this time, he has already contributed more than 100 articles in peer-reviewed journal. So may I request Vignesh to take up the podium for panel discussion on GIA. We have experienced this panel discussion for the last couple of months in this forum. Scholars Meet is a very exciting one because the young minds are contributing, they're discussing, and we have a lot of things we are learning from them as well. So Dr. Vignesh, please.
Thank you, sir, for the kind introduction. So, is my screen visible now?
Yeah.
Okay. Good evening, one and all. So thank you for giving me this opportunity to moderate this panel discussion. So we have this session on juvenile idiopathic arthritis. And for the discussion, we have 5 panelists here, Dr. Murugan Sudhakar, Dr. Pratap Patra, Dr. Satish Kumar Loganathan, and Dr. Akib Bande. So those are DM residents at PGI Chandigarh. And we also have Dr. Abhilasha Manvatkar, a DM resident from CMC Vellore. So we have heard an elaborate talk on laboratory methods. So this session is going to be entirely clinical. And I'm not going to dwell much on the therapy. So it's more on clinical recognition and to identify the JA mimickers. So we know JA, that is arthritis in one or more joints, which involve more than 6-week duration and in children less than 16 years of age. And we have these 7 categories given by ILR, the oligoarthritis, polyarthritis, RF positive, RF negative, systemic JA, enthesitis related arthritis, psoriatic arthritis, and undifferentiated arthritis. So moving on with the case. So we have a 4-year-old girl who walks into the OPD with a limp and does not bear weight on left lower limb. And on history, there was swelling of left knee with pain for the past 2 months. And the pain and limp was more during the morning hours. There was no fever. Child was active, looks non-sick. On examination, the left knee was swollen and was minimally tender, and other joints were normal. So this is the joint examination. Dr. Pratap, would you take up this clinical scenario and would like to give some of your differential diagnosis?
Yes, this is a child who is less than 16 years and having arthritis more than that is 6 weeks. So this is a chronic arthritis involving the single joint, this large joint, left knee joint. So the differential diagnosis in this case be either tubercular or oligoarthritis GIA. It can be enthesitis related arthritic or psoriatic arthritis, or it can be bilionodular synovitis, or it can be because of the So girls are unlikely to be hemophilia.
Okay, thank you, Dr. Pratap. So we have a 4-year-old girl with chronic knee monoarthritis, and Dr. Pratap has just described various differential diagnoses. So these are some of the important differential we consider whenever we encounter a child with chronic monoarthritis. In endemic country like us, we always consider TB, especially in monoarthritis, but usually the joint involved is hip. The knee is not the most common joint that is involved in TB. So whenever we have a chronic single joint, especially hip or knee, TB would always be a consideration. So Dr. Pratap, we have the investigations for this child. So can you interpret the investigations?
Yes, this child is having anemia, and the total leukocyte count is normal. The inflammatory parameter, the ESR and CRP both are high, and liver function test is normal. The chest X-ray is normal, and Mantoux test is negative.
Okay, so any other investigations you would consider in this child?
Yes, sir. I'll go for ultrasound examination of the left knee joint. And apart from that, I'll also investigate, I also rule out underlying HIV infection, hepatitis B and hepatitis C. And in this case, I'll also carry out an eye examination. I'll do a slit lamp examination of the eye.
Okay, so Dr. Pratap, you have just mentioned slit lamp examination. So why the child has not given any symptoms? Why you want to still go with the slit lamp examination for this child?
See, because seems to be oligoarthritis, and oligoarthritis is in this age group, very commonly associated with chronic enterouveitis that is non-symptomatic. So these children can have a uveitis before the onset of arthritis. So it is and unless we detect the uveitis, that can lead to blindness. That is a very severe sequelae that is associated with these conditions. So it is very important to screen all these children to detect underlying uveitis.
Exactly. So these children have chronic anterior uveitis. So that is usually not symptomatic. So they develop uveitis, and if not treated, they may land up in blindness. Any specific investigation would put these children at an increased risk of uveitis?
Sir, I didn't get you.
Any specific investigation, if that is possible, will that put these children into at increased risk of uveitis?
Sir, I don't know this answer, sir.
Okay, so what pattern of joint involvement you will see in oligoarticular JEA? Which joints are commonly involved?
In this group of children, mainly the knee joints, large joints are involved, and mainly they involve the knee joints and ankle joint. And to begin with, and hip joint involvement is extremely uncommon, and small joints also are very uncommon. They mainly present with a large joint involvement, and they can involve the knee joint, ankle joint, or elbow joint. Wrist joint at the beginning is also uncommon.
Exactly. So Dr. Pratap has clearly described joint involvement. So here in any patient with oligoarticular JEA, ANA positivity is associated with higher incidence of uveitis. So any patient with ANA positive JEA, so they are at very high risk of development of uveitis. So young girls, oligoarticular JEA, ANA positive, so you need to do a regular eye screening, that is the slit lamp examination for the development of uveitis. And joint involvement, as already said, it is the knee, which is the most common joint that is involved, followed by ankle, usually occurs in preschool children, girls more than boys, and often a well child. So usually these children walk into your clinic with a limp. An isolated upper limb joint involvement or isolated hip involvement is very unlikely in this condition. So moving on to case 2. So this is a 2-year-old boy with swelling of both knees for the past 6 months. There was no morning stiffness, and on examination, the bilateral knees were swollen. The child was diagnosed as a case of oligoarticular JA and was initiated on DMARD. But 3 months later, this child presented with diffuse swelling of right thigh, and ultrasound thigh showed muscle hematoma. And family history, the maternal uncle has increased bleeding tendencies in childhood, has received multiple fresh frozen plasma transfusion. Dr. Murugan, would you like to take up this case? So what do you think this child has? This child also has oligoarticular pattern of joint involvement, but something which is not looking like JA. So would you like to comment on this case?
Yes, sir. Since the history is somewhat odd, and there seems to be a family history also with the bleeding tendency, I will like to think differentials other than JA here, and mostly being a hemophilia kind of situation here.
Exactly. So APTT of this child was much prolonged, and this is a child with hemophilia. So Dr. Murugan, when will you consider arthritic presentation of hemophilia in children?
So in the natural course of hemophilic patients, the recurrent bleed into the same joint will later on subsequently produce a arthritis kind of picture. So these recurrent indolent bleeding episodes will keep on occur in them, and it will manifest as an indolent course of arthritis. So they will be like seen as a either mono or a poly large joint arthritis. Usually it is a monoarthritis kind of picture.
Yeah, usually it is when the children learn to stand up and walk. So they used to fall frequently and they get bleeding inside the knee joints or the ankles. So they can develop, they can come up with joint swelling. So this is actually not arthritis, it is a hemarthrosis. So this is a case of hemophilia which mimic. So this is the next case is a 11-year-old girl who presented with knee pain and swelling for 3-month duration. There was history of night pains, however, there was no fever. The child was otherwise normal. The workup for COX was negative. The X-ray was normal, but MRI has shown some abnormal finding in the lower end of femur. Dr. Akib, would you like to take up this case?
So, sir, we have a girl who has a knee pain and swelling, and there is significant history of night pains. So in night pains, and monoarticular likely swelling near the knee joint, so we would consider a malignancy as one of the possibilities. Or since because the child also has severe pains, so some of the benign tumors are also known to be notorious to be very painful, like osteoid osteomas, and they are in the metaphyseal. But malignancy will be a prime concern for us.
So exactly. So this is a 11-year-old girl who had osteoid osteoma at the lower end of a femur, which mimicked knee arthritis. So this child on X-ray, there was no much information, but when we did the MRI, so it showed a clear-cut lesion of osteoid osteoma adenitis, which we can clearly see at the lower end of femur. So this is a child with osteoid osteoma who mimicked with a clinical presentation of chronic monoarthritis. So we have a next case here, case 4. So she is a 12-year-old girl who presented with history of additive arthritis involving small joints of the hands and feet and later large joints for the past 6 months. She also had occasional intermittent fever. The arthritis was deforming. She has developed contractures, as you can see in the picture. And she also had active arthritis of bilateral wrists, elbows, knees, and ankles. And there was subcutaneous nodules present around the joints. Dr. Murugan, would you like to take up this case?
Yes, sir. So here, sir, I won't keep many differentials since you have given a history of inflammatory polyarthritis in a girl child with characteristic subcutaneous nodules. I would directly label the child as a polyarticular JA.
Okay, so this is the investigation of the child. So what is the possible diagnosis? You have already told it is polyarticular JA. So which type of polyarticular JA you would consider in this child?
Sir, there are two types, rheumatic factor positive and negative. But the history that you have provided is fitting with both the entities because there was no thing which is given about the symmetry or other parameters. So the next line of investigation I will consider here is IgM rheumatic factor by nephelometer and ANA.
Okay, so you have rightly said it's a polyarticular JA. So this is an RF positive polyarticular JA. The clinical presentation, it closely resembles the adult rheumatoid arthritis. So both large and small joints are affected. So the characteristic pattern is the symmetrical arthritis. affecting the MCP and PIP joints of the hands and wrists, and MTP and PIP joints of the feet. And deformities are well known in RF positive polyarticular JE. Whereas RF negative, it has a dual age group, one in the very young age, like oligoarticular, and one in around the adolescent age group. Here, the involvement is more asymmetrical. Knees, wrists, and ankles are the most commonly affected joints, and temporomandibular joints and cervical spine may be involved, and they may develop retrognathia. So, Dr. Murugan, how will you treat this child? What treatment consideration you would opt for this child?
So I shall be starting here on a NS side plus first line DMARD, that is methotrexate that we initiate here, which is preferably a subcutaneous form at 10 to 15 mg per meter square per week. And the situations where we would prefer biologicals or like high risk joints, such as involvement of cervical spine, involvement of temporomandibular joint at very early age, or a patient having a refractory VATs kind of situations where we'll prefer biologicals in the early part of the course itself.
So yes, so methotrexate should be started upfront, especially in patients with polyarthritis. This is the ACR 2019 recommendation. And if there is no responsive to methotrexate, that is generally taken as 3 months, then a biological plus DMARD is preferred. But the recommendations, they strongly recommend against using chronic low dose glucocorticoids in this age group. So coming on to the next case, we have a 7-year-old boy who has difficulty in getting up from squatting position for the last 3 years. The bilateral elbows and knees are swollen, non-tender, and the movements are restricted. PIP joints are swollen for the past 3 years, but there was no pain, and there was progressively increasing deformity of fingers. So these are the pictures we have here, and we have also done some radiology. So there was no signs of inflammation, and ESR CRP was normal. So Dr. Satish, can you comment on this case?
Sure. So in the child, there is no signs of inflammation, and the ESR CRP is normal. And this is like a arthritis mimicus. So most probably because of the platyspondyle, no signs of inflammation, ESR CRP is normal. Commonly, we see the arthritis mimicry is pseudo-rheumatoid or progressive pseudo-rheumatoid dysplasias.
Okay. So what investigation you would consider? So what are the classical findings you would see in radiology here?
Sir, X-ray platyspondyle will be there, anterior beaking will be there, and the metaphyseal enlargement will be there in the X-rays. And WISP gene mutation analysis is the investigation choice in the progressive pseudo-rheumatoid dysplasia.
So yes, so as you have pointed out, so it's a non-inflammatory condition. So here you would get joint stiffness that is progressive. You would see a classical symmetric swelling of the interphalangeal joints. So you could see the distal interphalangeal joints are also involved here, but it is a non-inflammatory arthritis. And if you do an X-ray, you would see the characteristic changes. You get metaphyseal enlargement, widened epiphysis. You would see narrowed joint spaces, short and wide femoral necks. Platyspondyly is nothing but flat and compressed vertebral body with anterior beaking of vertebrae. So this is pseudo-rheumatoid dysplasia. Dr. Akib, are there any other conditions with non-inflammatory arthropathy that can mimic the clinical presentation of juvenile idiopathic arthritis?
Sir, we can have, for example, we can have syndromes like Cooper syndrome, which can have there'll not be arthritis, but there'll be arthropathy. We can have the CACP syndrome, the camptodactyly arthropathy, constrictive pericarditis, and Coxa-Vara syndrome. So these are the two common mimickers. Sometimes even storage disorders like Fabry's can have, we can have GI, it can mimic GI. MPS is well known to mimic GI in pediatric population also. But we will have characteristic facial features in many of the MPS syndromes.
Exactly. So we have storage disorder, especially mucopolysaccharidosis, which can mimic the joint contractures, but of course you would have other features like mental retardation, Hosen facies, And radiology would give you a very good clue here. So here we have the shortened metacarpals, the proximal beaking of the metacarpals here. And we also have the inferior beaking of vertebra, the thickened cortex in the skull bone, and we have the rounded up ileum here. So we have characteristic radiological feature of mucopolysaccharidosis. This is called dysostosis multiplex. And idiopathic multicentric osteolysis, this is one other condition which could mimic a pseudorheumatoid dysplasia and JAA. Here you would get multiple contractures, and the characteristic radiological abnormality is the osteopenia, the classic osteopenia which you see here. And of course, Dr. Akib has rightly mentioned CACP syndrome, that is camptodactyly arthropathy, Coxa-Vara pericarditis. So here, the presence of camptodactyly is a very characteristic feature. And these children, they generally mimic polyarthritis kind of presentation because they develop multiple small and large joint enlargements, synovial enlargement, but there will be no inflammation. And if you do an X-ray hip, you will see the classical Coxa-Vara, and they will also have constrictive pericarditis. So they can develop heart failure due to it. So this is a child with CACP syndrome. Dr. Pratap, I would ask you to come to this case. So here we have a 4-year-old boy who had swelling of bilateral wrists and the MCP and the PID joints and the ankles and the knees. His father was diagnosed to have granulomatous uveitis few years back, and these are the pictures of his hands.
Yeah, this is bilateral symmetric arthritis and prominent synovitis, and the history of granulomatous uveitis in the father. This is with polyarthritis. Most likely is the case of Blau syndrome.
Exactly. So Blau syndrome, when you would consider Blau syndrome, so here, what was the point that pointed you that this is a case of Blau syndrome here?
So prominent tenosynovitis is quite prominent in the children with Blau.
So that is why they develop boggy synovium. So if you happen to do an ultrasound, you would see extensive synovial proliferation here. Any other important pointer?
So arthritis, uveitis, and rash, there is a triad for Blau syndrome that will be often present in the children.
So what is the characteristic rash they have?
They have rashes above the trunk, and these are polymorphic rashes.
Yeah, so they develop micropapillar lashes. So whenever you get autosomal dominant form of inheritance, polyarthritis, camptodactyly, always think of Blau syndrome. So we move on to the next case. So this is a 5-year-old boy who presented to outpatient with high spiking fever and well circumscribed evanescent salmon pink macular rash, which is present on the trunk and proximal extremities for 15 days. He also has history of swelling of bilateral knees and ankles. On examination, the child has pallor, lymphadenopathy, and hepatosplenomegaly. And the chest X-ray has shown pericardial effusion, and this was the rash which appeared during spike of fever. Dr. Akib, would you like to discuss this case?
Sir, if we have the given scenario in which we have the typical evanescent rash associated with hepatosplenomegaly and lymphadenopathy and features of effusion, that is basically serositis, so it would virtually favor the diagnosis of systemic JI. But if it would be only fever and lymphadenopathy or hepatosplenomegaly, then lymphoreticular malignancies and infections would be important differential diagnosis. And we could also have histocytic syndromes which could present as this. But with the rash and with serositis, it would strongly favor STI over all other basically diagnoses.
Okay, so Dr. Akib has correctly mentioned that this case is most likely to be systemic JA, but he didn't give a conclusive diagnosis of systemic JA because this is always a diagnosis of exclusion. There are many infections and lymphofollicular malignancies which could mimic the presentation of systemic JA. So this is the definition by ILAR: arthritis any number of joints together with fever for at least 2 weeks duration and accompanied by one or more of the following, which is the evanescent rash, generalized adenopathy, liver or spleen enlargement, and serositis. Dr. Akib, so this is the clinical course of the child. Over the time, the evanescent, Coccidian pattern has changed to continuous pattern of fever. The child has developed irritability and increase in spleen size. And the investigations has shown the platelet counts have started coming down. TLC have started to normalize here, and platelets have become normal. The ESR is dropping, but the CRP was increasing. So what do you think this child is developing now?
Sir, I would consider two important things. One is the clinical deterioration in the form of persistence of fever, irritability, and increase in the splenic size. And on the other hand, I can see that it appears to be somewhat a normalization of the abnormalities. So it basically is a macrophage activation syndrome, because it is not a clinical improvement that is we are seeing, but the investigations are, we may say that they are in a normal range, but we can see they are falling. The biochemical parameters are increasing, and the hematology counts and platelets and HB is falling. So we would strongly consider macrophage activation syndrome.
Okay, so Dr. Akib,
normal parameters.
Okay, so Dr. Akib, when would you consider treating macrophage activation syndrome? Would you like to do a bone marrow, confirm, and then start treating, or do you want to treat it right away?
Sir, it is a rheumatological emergency, and we should treat even if we have the slightest of suspicion, because it is a life-threatening illness. And by the time we confirm the diagnosis, we may have lost the opportunity to treat
Exactly.
save the life.
So as Dr. Akib has rightly pointed out, so this child was going into a complication, a devastating complication of macrophage activation syndrome. So we have a criteria, we also have decent criteria, but it is very important to recognize that it is the criteria, whatever we have, it's only a rough guide. So we need to recognize the clinical and laboratory features. The decreasing trend of the counts is more important rather than fulfilling the criteria, and don't rely on bone marrow. If you have the clinical features, which is very much suggestive of macrophage activation syndrome, it is very important to treat these children. Dr. Akib, we have a similar case scenario. This is a 7-year-old boy who presented to the outpatient department with history of right knee swelling with excruciating pain. He also has a history of fever for the last 2 weeks, and he usually wake up at night due to pains. He also has generalized lymphadenopathy and hepatosplenomegaly, and investigations you have right in front of your eyes. So what do you think this child has?
Sir, as I mentioned previously, presence of fever, arthritis, and organomegaly and lymphadenopathy strongly favors lymphoreticular malignancy. So that will be one possibility. And infections can be there because the history is acute only. So we would consider systemic infections also. Okay, but here, so neutrophilic leukocytosis with lymphocytic predominance, and platelets are on the lower side. In the pediatric population, we would always be interested in ruling out malignancy, hematological malignancy or lymphoreticular malignancy.
Okay, so you have you see the child is having a right knee swelling. So have you seen arthritis in a lymphoreticular malignancy?
Sir, in acute leukemia, arthritis can be the presenting manifestation. So it is a well-known presentation of leukemia in children.
So how will you differentiate arthritis in lymphoreticular malignancy versus arthritis in juvenile idiopathic arthritis?
Sir, the clinical pattern of arthritis, for example, the pain will be severe. It will be more in the night, and the child will wake up from sleep. Whereas the pain in JI does not usually wake the child up from sleep. Then secondly, it is more of a the swelling is more around the joint than in the joint. And it is due to the infiltration by the malignant cells in the bone and the periosteum. And then we can have features of other organ involvement, like we can have features of bone marrow involvement there. And we can have constitutional symptoms that also favor the diagnosis of malignancy: weight loss, night sweats, decreased appetite, that would favor malignancy.
Okay, and you also have bone pains, sternal tenderness,
yes,
severe bone pains, which you would not see in juvenile idiopathic arthritis. So thank you, Aki. So we have this case. Dr. Abhilasha has sent this case. So we have a 11-year-old boy who presented with chief complaints of pain in right hip and left knee and ankle joint for the last 9 months. It was associated with swelling and redness and early morning stiffness for around 2 hours. And on examination of the musculoskeletal system, we have tenderness over the hip joint, knee, and the ankle joints. And the child also has pain at the insertion of Achilles tendon in the right side. However, the range of motion in the ankle joint was normal, and the sacroiliac joint examination was normal. Dr. Abhilasha, would you like to take up this case?
Yes, sir. So this is a 11-year-old boy with inflammatory oligoarthritis with predominant involvement of lower limb and associated with enthesitis in form of involvement of right greater trochanter and Achilles tendon insertions. So it's mostly looking like a case of enthesitis related arthritis.
Okay, so how would you proceed with this case? What further examination or what further investigations you would consider for this child?
Sir, as per the first, we have to include this patient in an inclusion criteria in which, as per the ILR criteria, patient is either having arthritis and enthesitis or arthritis or enthesitis with any of the following two, with inflammatory sacral pain, sacroiliac joint tenderness, HLA-B27 positivity, or one set of arthritis in male with more than 6 years of age with acute anterior uveitis and first degree relative with HLA-B27 associated diseases. We have to exclude other diseases like RF positivity with in two separate occasion at 3 months apart, systemic GI, and first degree relative with and personal history of psoriasis.
Okay, so as we have seen here, so this is a male child, an older male child with lower limb predominant arthritis. So this is a classical presentation of ERA. So this is the only type of JA where we can see male preponderance. So Dr. Abhilasha, what is the pattern of joint involvement in enthesitis related arthritis?
In enthesitis related arthritis, we will see lower limb, oligoarthritis, and asymmetrical type of involvement.
Okay. And how would you screen for sacroiliac joint involvement or enthesitis in the outpatient?
In outpatient for sacroiliac joint involvement, sir, we have classical Schober's and modified Schober's test. And other than that, we are having some provocation test. There are 5 provocation tests are there. First is the distraction test, where we have to give outward pressure over anterior superior iliac spine, which will cause pain in sacroiliac joint. Second test, here we have, with one hand we have to stabilize the opposite side of anterior superior iliac spine, and with another we have to flex hip and knee, and we have to give downward thrust, which is called a thigh thrust test, where and it will elicit the pain in that sacroiliac side. Third test is the Faber test. In Faber, we have to keep the limbs in figure of 4, and we have with the other hand we have to stabilize the anterior superior iliac spine, and other hand we have to give pressure over the knee joints, which will elicit pain in the sacroiliac joint where it is flexed. The fourth test is the compression, where we ask patient to lie on one side of the table, and we have to give pressure or anterior superior iliac spine, which will cause pain and pain in sacroiliac joint. The fifth test is the Gensler's test, sir. Here it will give a rotational movement. Here we have to ask patient to lie on the edge of the table with one legs are hanging on the side of the table, and the other leg is flexion with flexion at the hip and knee joint, and we have to give pressure on the knee joints. And if it's giving a rotational force to that SI joint, and which will elicit the tenderness. So, sir, if any of the 3 tests are positive, it's a good discriminative power for diagnosis of SI joint involvements.
Thank you, Dr. Abhilasha, for your very good description of clinical examination of sacroiliac joint. So, as she has rightly pointed out, so it is the asymmetric oligoarthritis of the lower limbs, And especially if you see sacroiliitis or bursitis, it is the inflammatory arthropathy of midfoot. It is extremely suggestive of enthesitis-related arthritis. And HLA-B27, it is present in 50 to 70% of these patients. It is generally associated with higher disease activity. So enthesitis, Dr. Abhilasha, you want to comment on what are the sites that you would
Yes,
look
sir.
for?
So antithesis is basically the attachment of joint. So antithesis is basically the attachment of capsule, tendon, fascia, and ligament to bone. So and its inflammation we call it enthesitis. So in anthesitis related arthritis is a symmetrical type of enthesitis, predominantly lower limb, which is but the pain which is asymmetrical in whereas the enthesitis is a symmetrical lower limb. And most common and in enthesitis involvement is the patellar ligament, plantar fascia, and Achilles tendon. To elicit enthesitis, we have to give pressure over the enthesial attachment for example, in patella at 2 o'clock, 10 o'clock, and 6 o'clock position in tubular tuberosity and or calcaneal tuberosity where Achilles tendon is attached. For plantar fascia, we have to ask patient to lie prone, and we have to give pressure over the calcaneal tubercle, and we have to slide our fingers slowly downwards to look for other plantar fascia attachments. So for plantar fasciitis.
Uh, okay, so uveitis can happen in enthesitis-related arthritis also. So
Yes.
how uveitis is different from that seen with oligoarticular JA?
As my colleague already mentioned, that oligoarticular GI is a asymptomatic chronic type of uveitis, whereas in ERA it's a symptomatic acute unilateral recurrent type of uveitis. So for articular GI, which is asymptomatic, we have to screen once every 3 to 4 months, but in ERA we can screen for, once in a year.
Exactly.
Of uveitis.
So uveitis is unilateral and it's painful uveitis, whereas it is painless, chronic, bilateral in oligoarticular JA. So Dr. Abhilasha, when would you add DMARD in enthesitis-related arthritis, and what DMARD you would prefer, and when would you consider adding biologicals in these patients?
Okay, so for this, I would start with the ACR 2019 recommendation. In ACR, they have told for polyarthritis. My colleague already mentioned the treatment for sacroiliitis and enthesitis in enthesitis-related arthritis. They have recommended first to start with NSAID, which is strongly recommended, and after that, if after 1 month, if there is still inflammation, we have to straightforward go to adding TNF5, which is strongly recommended, or continuation of NSAID monotherapy. Or if TNF5 are contraindicated, we can try sulfasalazine. And there are some open label studies which shows SARS is beneficial for axial involvement, but some RCDs are not showing beneficial effect of SARS in GI with axial involvement. But as per ACR, methotrexate monotherapy is strongly recommended against in GI with sacroiliitis. And for GI with enthesitis, again first try with NSAID for 1 month. If NSAID if there is still inflammation is persistent, we try for TNFIs or methotrexate and sulfasalazine. And they have also recommended bridging therapy here also, which is less than 3 months. And but for enthesitis, intraarticular treatment is not advised because repeated injection will cause tendon injury. So.
Exactly. So repeated intraarticular injections are not preferred in enthesitis. So which DMARD you would prefer here? You would either use sulfasalazine or methotrexate in case of sacroiliitis.
For sacroiliitis axial involvement, I would prefer sulfasalazine, and if still there is active arthritis, I would add methotrexate or sulfa.
Okay, thank you. Thank you, Dr. Abhilasha. So we have the final case for today. So this is a 5-year-old girl who presents to OPD with right knee arthritis the last 3 months, and on examination she was noted to have distal interphalangeal joint arthritis of the first and second fingers. And the family history, the father is being treated at dermatology department with topical skin creams and phototherapy for the last 8 years. Dr. Satish, would you like to take up this case scenario?
Sir, this is 5-year-old child presented with right knee monoarthritis for the 3 months. But the unusual thing is the DIP joint also involved, and the family history also, the father is treated in the dermatology department with the topical skin creams and the phototherapy for the past 8 years, sir. In the history, the DIP joint and the family history is very significant in this child.
So what would be your diagnostic consideration?
Sir, I will be considering, because of the family history, father is like treated with the topical skin creams with a prolonged duration. I'll be thinking of juvenile psoriatic arthritis in this child.
Okay, so how is juvenile psoriatic arthritis? The clinical presentation is different from other forms of JAA. Do we have any specific clinical manifestations here?
Sir, juvenile psoriatic arthritis, there are 3 types of presentation is there. They can present with enthesitis, peripheral arthritis, and the axial arthritis also they can present. This is 3 types of presentation we can see in the patients with the juvenile psoriatic arthritis.
Okay.
And the small joint DIP joint involvement, and if the joint chronic arthritis is going on, the sausage digits also we can see in psoriatic arthritis.
So we have the ILR criteria here. So inclusion is either arthritis plus psoriasis or arthritis plus at least 2 of the following. It is the dactylitis or the presence of nail pits or onycholysis or the family history of psoriasis in a first degree relative. So as Dr. Satish has already told, so there is 2 important types of presentation of psoriatic arthritis. One is oligoarticular JA type of presentation, and number 2 is ERA kind of presentation. So the number 1 is the young girl with the asymmetric oligoarthritis involving the lower limb joints, NA positivity, and they carry increased risk of uveitis. The important point to note here is the presence of dactylitis. Dactylitis is very characteristic of psoriatic arthritis, and also the involvement of distal interphalangeal joint inflammatory arthritis. So that is also characteristic of psoriatic arthritis. And the second pattern is the older boy who has lower limb arthritis with HLA-B27 positivity, and they run an increased risk for spondyloarthritis. So any child where you encounter with inflammatory arthritis, always look for these nail pits. So these could be one of the clues for psoriatic arthritis. The second figure here shows the dactylitis. Dactylitis is nothing but diffuse swelling of a finger which is extending more than a joint. So we come to the end of the session. So it is very easy clinical pattern. So if you have a young girl, lower limb few joints, it is oligoarticular JA, do ANA, screen them for uveitis with a slit lamp examination. When you have an old boy, lower limb few joints, it is HLB27 related arthritis, and usually the uveitis is acute symptomatic. If you have an adolescent girl with multiple small and large joints, which is deforming, it is RF positive polyarthritis, which has a very poor prognosis. And you have any age with high-grade fever, evanescent rash, consider systemic juvenile idiopathic arthritis, but again, it is a diagnosis of exclusion. So it is a study of pattern and associated systemic features, which will diagnosis. So we have seen that all types of JA have distinct patterns, and any deviance from the pattern, you must always look for the mimickers. So if there is any oddity in the clinical presentation or response to therapy, should make you suspect alternative diagnosis. We have seen a case from Professor Surjit Singh sir has shown an arthritic presentation of X-linked A-gamma globulinemia. So that was a child with polyarthritis, but the history has revealed significant recurrent infections. So that was the pointer which told us that it is not a simple JA and it is something more. So that's when we got the immunoglobulins done, and it turned out to be XLA. So whenever and there is any deviance from the pattern, you have to look for mimickers. And we have seen from the case scenarios, whenever there is bone pain and night pain, look for malignancy. And when there is progressively increasing deformity, with or without spine involvement, skeletal dysplasia should be considered. And radiographs in selected cases may point towards an alternative diagnosis. Thank you very much. Thank you, the organizers.
Thank you, Dr. Vignesh. So are we at the end of the session, Argo?
Yes, sir.
Today was very unique in the sense we had most of what was there was something that we all don't know. So pediatric, primary immunodeficiency, and then the lab workup, and then now this GIA is something that adult rheumatologists are also not familiar with, and I think it's something that we all should have known. So excellent session today. The next, I think, will be in the 3rd week of January, and we're having scientific communication and critical appraisal. I think those are on the cards. So that will be something, again, very useful for all of us, actually, especially the fellows, and looking forward to that. There is no IRA webinar this month. We'll be sending an email to all, for the fellows also, and for everybody, actually. And because of Christmas and New Year, we are keeping it off. We'll do it in January. It's on vasculitis. So with wishes for a Merry Christmas and a Happy New Year to all of you. 2020 has been sort of memorable for all of us. We remember lifetime, all of those who were there, but hopefully we've learned a lot from it. So with that, we'll move to the next, into the new year. Thank you, all of you. Thank you all.